All right, let's jump right in. Welcome to this explainer tailored specifically for you, PG medical students. Today, we're unpacking a highly technical and honestly fascinating anatomical study on the uterosacral ligament. As future pelvic surgeons, you guys already know that the margin between a beautifully executed reconstruction and a major surgical complication is literally measured in millimeters. So this paper, titled Quantitative Analysis of Uterosacral Ligament Origin and Insertion Points by Magnetic Resonance Imaging, is a real game changer. It gives us the objective, hard spatial data we need to navigate the deep pelvis with absolute confidence. We're going to look at exactly how these researchers managed to visualize these notoriously tricky soft tissue structures, and more importantly, how you're going to apply this very data the next time you step into the OR. Here's the game plan for today. We'll start with the pelvic surgery challenge, look at the MRI methodology, quantify the origin points, quantify the insertion points, and finish up with the clinical and surgical implications. Let's get to it. Section 1, the pelvic surgery challenge. Okay, so navigating the deep pelvis during complex cases, like a really difficult hysterectomy or an intricate apical prolapse repair, is incredibly demanding. The anatomy is tight, vital structures are densely packed together, and let's be real, visibility is often totally compromised. Relying on fuzzy textbook approximations just isn't going to cut it when you're actively trying to restore pelvic floor support without hitting neurovascular bundles or nicking the ureter. So, to make sure we're on the exact same page as the researchers, we need a strict baseline. In this study, the uterosacral ligament is defined by its entire spatial continuum. We're just looking at some mid-substance snippet here. The boundaries stretch from the precise fascial origins way out at the pelvic sidewall, swooping all the way down to the exact distal insertions anchoring into the cervix and vaginal vault. Having this incredibly strict, standardized definition is exactly what makes the MRI data we're about to look at so reliable for us clinically. Moving right along to Section 2, MRI methodology and approach. So how do they actually map this? Well, the researchers' approach breaks down into 3 very logical steps. Step 1 was rigorous patient selection, essentially making sure they had a reliable cohort with no prior pelvic distortions. Step 2 was the use of high-resolution T2-weighted MRI protocols. Now, as PG students, you know T2 weighting is the absolute gold standard for popping out complex soft tissue contrast in the pelvis. It's what allows those ligamentous fibers to really stand out against the surrounding pelvic fat and visceral structures. And finally, step 3, meticulous 3D mapping and spatial quantification. They literally took the ligament from being a flat, 2-dimensional shadow and turned it into a fully measurable topographic roadmap. Which brings us to Section 3, quantifying the origin points. Now, check this out. The researchers quantified a critical metric here, 15.0 millimeters. That is the median distance from the uterosacral ligament origin to the ischial spine. Just think about when you're passing a suture for a uterosacral ligament suspension. Knowing this exact 15 millimeter distance means your suture placement suddenly has a distinct, evidence-based margin of safety. You're no longer just guessing where the strongest fascial tissue originates. You have the actual data to target it perfectly while totally avoiding neurological impingement. It's huge. And here's another thing. We often have this habit of treating the human body like it's perfectly symmetrical, right? Well, this high-resolution mapping completely busts that myth, proving that structural variances absolutely exist between the left and right pelvic sidewalls. Understanding these minor, yet statistically significant discrepancies prepares you for the asymmetric tension you might actually feel during a bilateral suspension. Honestly, recognizing and anticipating these right versus left differences is a true hallmark of an advanced pelvic surgeon. Okay, let's travel distally for Section 4, quantifying the insertion points. We are officially in the heavy lifting zone of the ligament, 4.5 millimeters. That is the median thickness right at the distal insertion point. And look, this isn't just anatomical trivia. This 4.5 millimeter value represents the literal load-bearing capacity of the tissue you're working with. When you're doing a vault suspension, this hard number dictates your bite depth. It dictates your suture selection. If you don't respect the actual physiological thickness here, you are risking tissue pull-through or just flat-out inadequate support. Memorizing this structural integrity metric is absolutely foundational for ensuring your repairs hold up over the long haul. It's really fascinating because the ligament dynamically changes shape as it travels. You can clearly see the contrast in structural dimensions between the origin and the insertion. At the origin, it's completely fanned out and wider, which makes sense. It needs a broader distribution of tension against the pelvic sidewall. But down at the insertion, it becomes highly condensed and much narrower, actually shifting its spatial angles as it integrates into that dense fibromuscular ring of the cervix and upper vagina. Grasping this morphological taper is what allows you to restore true anatomical alignment, rather than just blindly pulling tissue together and hoping for the best.
Finally, let's wrap this all up in Section 5, Clinical and Surgical Implications.
So we have to ask ourselves the million-dollar question: how do we take all of this quantitative MRI data and use it to actively avoid ureter injury during a complex reconstruction? You know the ureter intimately crosses the uterosacral ligament. By internalizing that 15-millimeter median distance from the ischial spine and that 4.5-millimeter structural width at the insertion, your mental map of the danger zones becomes vastly more accurate. This data literally gives you defined surgical boundaries. You can dissect, you can place trocars, and you can drive needles with a mathematically backed understanding of exactly where the ligament ends and where the ureter begins. The researchers hit the nail on the head with this core takeaway. Respecting these exact mapped dimensions is simply non-negotiable if we want to reduce surgical morbidity. Superior outcomes in apical prolapse repair don't just happen by luck, right? They come from an uncompromising respect for exact anatomical parameters. When you align your technique with this quantitative data, you significantly decrease the risks of ureteral kinking, nerve entrapment, and vault recurrence. At the end of the day, the anatomy dictates the outcome. So as you head into your next rotation and scrub into your next major pelvic case, I want you to consider this. Given the immense variability and the complex 3D structures we've mapped out today, will creating an individualized patient anatomy map via 3D MRI soon become your standard pre-op protocol? I mean, if high-resolution mapping can objectively reduce complications and let you tailor the surgery to the specific angles of the patient right there on the table, we might literally be looking at the future of advanced pelvic surgery. Thanks for joining me for this explainer. Keep studying those anatomical margins, and I'll see you next time.